are my co-faculty who would be moderating the session, Dr. Sanat Phatak, who's a consultant rheumatologist with KEM Hospital, Pune, and Dr. Sushant Shinde, a consultant rheumatologist from Mumbai. And I think to the students, they need no introduction. The student today that we have is Dr. Shruti Nelekar from Sion Hospital, Mumbai. She is a fellow in Sion Hospital. Her mentors are also joining. So, as you know, each time that we do our journal club, we are trying to pick up different types of studies with different research methodologies, different papers, so that the students get an idea of different types of studies in literature so that they can interpret literature with ease. So today, our students has chosen a systematic review on targeted therapies in inflammatory arthritis with a history of cancer. I think this is a very relevant topic in today's world. So I request all the other students who have joined, other fellows and residents, to also be attentive so that we can ask them questions as well. I just want this to be an interactive learning experience for all of us. So without wasting further time, let me hand over to Shruti to share her slides. You can start your presentation, Shruti.
Andaman.
Shruti, you need to unmute yourself.
Sorry, sir. Sorry. I'll begin.
Please start.
Okay, you can go to your first slide, Shruti.
Yes, ma'am. Actually, it's not getting operated. Yeah. So a very good morning. Should I start, ma'am?
Yes, please do.
A very good morning to respected faculty members and my colleagues. I'm Dr. Shruti, and today I'll be presenting a journal article on targeted therapy in inflammatory arthritis patients with history of malignancy. Potential association between targeted therapies and in patients with inflammatory arthritis and a cancer are frequent concern in our daily rheumatology practice.
Shruti, your slides, they're moving now.
Yeah. So rheumatic diseases can be associated with malignancy in a variety of ways. They can be a part of paraneoplastic syndromes, or rheumatic diseases can be associated with an increased neoplastic risk due to chronic inflammatory status, as lymphoma or lung cancer in rheumatoid arthritis, lymphoma with Sjogren's, or psoriatic arthritis may be associated with breast cancer, or GI malignancies with ankylosing spondylitis, and hematological malignancies with both. Hence, cause is difficult to define in many situations, and attribution only to disease activity or treatment is a question. Biologicals and cancer risk. Immune competence is extremely essential for tumor surveillance. Use of biological leads to immune incompetence, which may lower our host surveillance against incipient tumors and accelerate the tumor progression. So why are we really concerned about biologicals and cancer? Till now, most of the research has focused on TNF inhibitors, and TNF inhibitors were suspected to increase the tumor risk by interfering with the immune system. Lymphoma and non-melanoma skin cancer were the concern associated with TNF inhibitors. Concern was increased when in 2002, FDA report of 26 lymphoma cases in RA patients treated with infliximab and etanercept was published. As we always know that TNF inhibitors are related in many articles with non-melanoma skin cancer. Risk of melanoma with abatacept is well studied. Hence, prescribing biological demands in patient with history of cancer, is it safe or no? Most of the randomized controlled trials have excluded patients with history of cancer, which limits the use of biologicals in this population. Also, some recommendations suggest waiting for at least 5 years of oncological remission before initiating targeted therapy. Against it, in 2015, ACR recommendations for treatment of RA recommended that patients with history of previous solid malignancy and RA should be treated as once without these. Hence, no consensus is available regarding use of biologicals in this population. Also, time period from cancer diagnosis until safe initiation of biologicals is not mentioned anywhere. Hence, we have reluctancy to start biologicals in such populations, especially TNF inhibitors. This may lead to undertreatment of these patients and disease activity cannot be controlled in this population. These are some studies. The studies published in JAMA in 2006 by Bogarts et al., Solomon et al., or Bergen, they have concluded increased association of TNF inhibitors with lymphoma or non-melanoma skin cancer or abatacept with melanomas. Whereas some registries like the British Society of Rheumatology BSRBR registry or the ARTIS or the Danbio group concluded against these results, which concluded no association of TNF inhibitors or rituximab with lymphoma. So now, taking this scenario into consideration, there was this article which was published in Annals of Rheumatology in December 2024. Systematic literature review and meta-analysis informing Euler points to consider on initiation of targeted therapies in patients with inflammatory arthritis and a history of cancer. The study objectives were to perform a systemic review to inform task force formulating points to consider on initiation of targeted therapies in patients with inflammatory arthritis and a history of cancer. Methods used. Literature search was done in PubMed via Medline and Embase. They included recent abstract from large international congresses between 1 January 2010 to 15 July 2022. The inclusion criteria being studies reporting relative risk measures, that is hazard ratio for new cancer or cancer recurrence in inflammatory arthritis patient initiated on targeted therapy group versus a comparator group which was a conventional synthetic DMARD group. Type of analysis is systemic literature review and meta-analysis. The PICOT framework for it is the population taken was patients with history of cancer who were initiated on a targeted therapy for inflammatory rheumatic, bowel or skin disease regardless of time since initiation of cancer diagnosis. The intervention group was the patient who had received targeted therapy, that is either a biological or a targeted synthetic DMARD. The comparator group was patients who received conventional synthetic DMARDs. Outcome which was studied was new incident cancer or cancer recurrence. The time for which the data was collected was 12 years, that is from 1 January 2010 to 15 July 2022. The data extraction and outcomes studied were: the study design was a cohort registry based design. The type of inflammatory arthritis which were included were rheumatoid arthritis, psoriatic arthritis, axial spondyloarthropathy, and IBD associated arthritis. The type of therapy which were included was conventional synthetic DMARDs, biological DMARDs, and targeted synthetic DMARDs. The primary outcome was new cancer or a cancer recurrence. Measure of effect was hazard ratio with 95% confidence interval, and the hazard ratio was adjusted for age, sex, cancer type, and inflammatory arthritis type. The meta-analysis approach was, it is a random effect model chosen due to heterogeneity among the studies. Heterogeneity was assessed by Cochrane's Q test and I-square statistics. The risk of bias was excluded by Robinson tool, and publication bias was assessed by funnel plot. Quality of each study was studied by the Newcastle-Ottawa scale. Now, before we go to the results, let's study what is basically a forest plot and a funnel plot, because all the results are concluded in these plots. Now, forest plot is a graphical display of estimated results from a number of scientific studies which address the same question along with the overall results. Now, this is an example of a forest plot. Now, here as we can see, each study is included in each horizontal row. The horizontal bar, so the vertical line which we can see is the line of no effect, which will signify no difference between the two groups. The horizontal line which we can see across each study is the confidence interval. The width of the line is a confidence interval. The rectangular structure which we can see in the between is a point estimate. The width of the point estimate will tell us the weight of the study. Now here a diamond shaped structure we can see at the bottom is a overall estimate, which will be the overall estimate calculated in the whole study. The heterogeneity is given by the I-square statistics, and significance of the test is given by the p-value. So confidence interval is a range of values that the estimate where true population is likely to fall. Now, what is a funnel plot? It is a scatter plot in meta-analysis in which we visualize publication bias. The x-axis will tell us about the effect size, like the odds ratio, relative risk, hazard ratio, etc. And the y-axis will tell us about the precision of the study, like the standard error. Now, each dot is an individual study. This is the line of overall effect. So the triangular structure in which it will fall is the 95% confidence interval. Symmetry or asymmetry of the funnel plot will tell us about the existence of publication bias or no. Now results.
Right. Shruti, let me just interrupt
ma'am.
you.
Yes,
Yeah,
ma'am.
let me just interrupt you here. So, for the benefit of all our students, you have very well talked about the background of the study,
Okay, ma'am.
as also the methodology.
Yes, ma'am.
So, can you just recapitulate one more time? Why is there a research gap in this area, in this topic? Why did they choose this topic at all to do
Okay.
a systematic review?
Okay, so ma'am, we have two thought of ideas which are available till now. Some studies tell us that using biologicals in patients with history of cancer will increase further risk of newer recurrent cancers like lymphomas or non-melanoma skin cancers with TNF inhibitors. Most of the studies have focused on TNF inhibitors. Uh, some studies also tell us that it is safe to use these drugs, while some studies tell us it is not safe to use these drugs. So, no set of guidelines are available right now to tell us whether to use or not to use. Hence, this task force postulated some points to create EULAR points to consider and some overarching principles for our daily clinical practice in such patients.
Okay, so why do we think that there is such lack of research? Because uh, in all RCTs, we are excluding this group of patients,
Yes,
right?
yes, ma'am. Yes, ma'am.
Patients with malignancy.
Yes, ma'am.
Okay, Sanat, you want to ask her anything at this point?
No, she can go on.
Yes. So results, primary analysis, 15 articles were included, of which 14 were observational study and one was an abstract. Now this is a based flow diagram which tells us about the initial identification was done of the databases via PubMed and Embase, which included 1555, of which some were removed as duplicates. Then records screened were 1093, out of which 1014 were removed because there was no mention of cancer in the title or abstract. 79 were selected for eligibility, of which 15 were selected. So median age at cancer diagnosis was 52.5 years. Median follow-up was 4.52 years. Median time from reported index case of cancer to initiation of targeted therapy was 4 years. Now these are some population characteristics in the study. Type of cancer, 90%, more than 90% studies included solid tumors, 2 breast cancer, 1 melanoma, 2 non-melanoma skin cancers, and 1 squamous cell carcinoma of head and neck. Type of inflammatory arthritis, maximum of them were rheumatoid arthritis, that is 12 studies. 2 were IBD associated arthritis, and 1 was a combined study of rheumatoid arthritis, IBD associated arthritis, and psoriatic arthritis. Type of targeted therapy used, maximum patient received TNF inhibitors, and minority received vedolizumab, ustekinumab, rituximab, and no study included targeted synthetic therapy. So, our primary endpoint, which was new cancer or cancer recurrence reported, so 460 new cases or cancer recurrences were found in the targeted group, whereas 1394 new cancer or recurrences were found in conventional synthetic DMARD group. Among the biological group, maximum of the cancers or recurrences were found in TNF inhibitor group, but these were the drugs which maximum patients received. The pooled hazard ratio for new incident or recurrent cancer recurrence between biological group and control group, which was a conventional synthetic DMARD group, was 0.9%. Now, as we can see, it is a summary of all the 15 cases studies included in the meta-analysis. Most of the studies fall to the left of the line of no effect, and the overall summary estimate also is to the left of the line of no effect, that is the hazard ratio being 0.90, which concludes that there is no increased risk of starting biological DMARDs in patients with inflammatory arthritis and a history of cancer. This is a funnel plot. In the funnel plot, we can see all the single studies which are scattered evenly along the line of common effect. Hence, no publication bias is seen in this study.
Shruti, could you just sorry,
Yeah,
to
just go
interrupt.
back to
Could you
the
just go
forest
back
plot.
to the forest plot exactly?
Yes, sir.
Can you repeat your interpretation here?
Yes. So here we can see each study against in a single row. We can see the point estimates. Maximum of the point estimates are to the left of the line of no effect. So this will indicate that it favors the biological DMARD group, which will indicate that there is no increased risk with starting biological DMARDs as compared to conventional synthetic DMARDs in patients with inflammatory arthritis and a history of prior cancer.
So, can you just interpret for me the
Yes, sir.
line that has been written higher up there, that the pooled hazard ratio is 0.90 with 95% confidence interval between 0.74 to 1.10. How do you
Yeah.
interpret that line? What does that mean?
A 95% confidence interval is the range between which maximum of the population is estimated to fall. So 0.9 is the summary estimate, pooled hazard ratio. So if hazard ratio is less than 1, this will indicate that there is no significant difference between the two groups, and the intervention we are using will favor our outcome.
So if it is less than 1, it favors your outcome.
Yes,
But
sir.
that is about the mean value, that is your 0.9. But
Yes,
does the confidence interval tell you anything about whether your results are significant or non-significant? Does it help you that way? Statistically,
uh,
are your results significant, or are they by chance?
sir, confidence interval will tell us about what the majority of the population will fall into.
Yeah, but what has that to do with the central line? So if you look at your diagram,
Yeah.
the
Mhm.
last red line that you have,
Mhm.
it crosses the
Crossing the line is
central.
no difference.
Yeah. So
Yes.
What
why
is
does
that
it
tell you?
cross it? Yeah. What does that mean?
Sir, because all the studies have not shown the results which we have. So different studies have got different results, but we are taking the estimate of everything.
Fair enough. That's the estimate is coming to 0.9.
Yes, sir.
My question is about the confidence interval. If it is crossing 1, that's the answer.
Mm-hmm.
If it is crossing 1,
Mm-hmm.
does that signify anything? Does it mean anything to us? If you take any of these lines in the forest plot, in the central y-axis, you have a line which is
Yes, sir.
corresponding to 1 hazard ratio. And you have
Yes.
all the other lines which seem to be zigzag crossing it. You
Yes.
nicely describe that the center point is the mean, and then you have the confidence interval. But if the confidence interval is crossing that central 1 line, how
Oh,
do you
yes.
interpret that?
So if it is crossing one line, then it will be difficult to conclude because that will signify it will not favor the results as it is. If it is to the right of the line of no effect, then it will favor the other groups. Sir.
Okay, so
No,
we can
no, no, that's
also,
not.
yeah,
No,
yeah,
that's not correct. I
yes.
mean, it's not. You're not talking about favoring any result if it's
Hmm.
crossing a line.
Mm-hmm.
What is confidence interval anyway? Like, tell me just, I mean, without this particular context, even what is confidence interval? Like, what do you mean by a 95% confidence interval? Because I don't think that is clear from what you're saying.
Okay, so 95% confidence interval is the range between which 95% of the population, that is maximum of the population, results will fall into.
What do you mean?
That is, those results can be attributed to 95% of the max 95% of the population which is included in the study.
What?
There isn't one study, no? So how
Yeah.
can you say that 95% of the population included in this? It means something else, that 95%
No.
stands
So
for
if you're
something
talking about
else.
one study, suppose you're talking about 95% confidence interval, it doesn't need to be in a meta-analysis. If you're talking, let's say, about 95% confidence interval in a clinical trial, why does that need a 95% confidence interval? You have your data, you have 100% of your population that you've analyzed. Why does that need a confidence interval? Why do you need to make separate speculations about 95%?
Sir, because
All
the
your
research
population you've
from-
analyzed. No, even in this study,
Mhm.
even in a meta-analysis, you've analyzed everything. So why do you need to make speculations about 95%? So what population are you talking about here?
So I didn't get the question actually.
So maybe
Is
Sanath,
it-
if we could ask this question to
Ask
some other
Some
residents
other
also.
residents?
Yeah.
So
If there are other
So
residents
does
who would
anybody
like
want to
take the
volunteer
question.
what a confidence interval is?
So do we have residents here?
Yes,
If they
we
are,
do.
can you just raise your hand? There's a raise hand option. You should know who's there at least. So,
Yes, anybody wants to volunteer this?
Hello.
You can just try. Yeah, Akanksha.
Uh, Good morning, everyone. I'm a resident from Bharati Vidyapeeth. Sir, I would, according to me, the confidence interval, if the study was to be repeated in another set of population,
Hmm.
then the chances of the mean falling 95% of the times falling within this range is what the confidence interval means, I think.
Yeah. So essentially, I
close,
mean, this is true about most things that you do in inferential statistics, where you have a sample and you have to make some statements about the entire population. So all you're doing here is trying to say if your sample is representative of the entire population. So if you do this same kind of sampling every time, then you want to say that if you do 100 times, then in 95 cases, the value will still fall within this particular limit. So that's what population is. So you're trying to make estimates of the entire population based on your sample.
Yes,
So
sir.
it's not about 95% of what you've already analyzed.
Okay, sir.
Because what you've already analyzed, you don't need to make speculations, right? It's already there in front of you. Why do you need to make any? Why do you need uncertainty when everything is certain? It's in a table in front of you. So all of this is speculation about the population at large based on the sample that you have.
Okay, sir. Okay.
So what does a wide? Where is the plot?
Can you see it?
Forest plot?
Yeah, is it seen just now?
yeah,
Yeah,
it's
it's
there.
seen. It's seen.
Oh, it's there.
Go back to
Okay.
the
previous one.
slide. Yeah. Can you see it?
Yes.
Okay. So which is a good confidence interval here? Which is a bad confidence interval? What do you think?
Sir,
So you have so many studies in front of you, 5 and 5, 10 and yeah, I mean about 15
Yeah.
to 17 studies. So which one of these is a good confidence interval?
the one which does not cross the line of no effect is a good confidence interval.
No, that's not good or bad. I mean
Okay.
that's their results. So that is fine.
So,
So
sir,
would you
weight,
want a wide one or a narrow one?
Is
Yeah.
it the width that tells you?
wide width will matter because that will be associated with increased weight of the study.
No, width of the
No.
line.
No.
Width
So
of the
we are
confidence
not
interval.
talking. Don't talk about weight. Don't talk about meta-analysis for now.
Okay.
In general, in a confidence interval, suppose you have Valji et al. 2019 has a very small confidence interval, right? I mean, it's pretty narrow, while I think it's Altonen 2015 has a very wide confidence interval,
Mm-hmm.
if you see in this forest plot.
Yes, sir.
So which one of these is better?
So the narrow one will be better because the results will be the range will be between a short interval, that is more, we can say,
So what is such a study called? If the confidence interval is short or small, do you know what that is called?
no, sir.
So that study is called precise. So that is how you
Precise. Okay.
define precision.
Okay, sir.
So it's a small is what is called a precise confidence interval. And what will that tell you if a confidence interval is precise? Suppose you have that 0.56 to 1.21 there, and here it's 0.22 to 22.38 in Altonen.
Mm-hmm.
So what does that tell you? Why is that one better than the other?
So the precision of the study will again tell you the applicability to the general population.
Yeah. So, I mean, then you're reasonably certain that if 95% falls into one of those, then it's actually an estimate that you can rely upon.
Yes, sir.
If it's 0.22 to 22, then where would your real estimate be is the question.
Yes, sir.
Okay.
Should I proceed?
And then how would you weight these?
Sir, the weight of the point estimate, which is besides each study, will tell
Yeah.
us the width of the point estimate will tell about the weight of the study, which will be again influenced by the sample size.
Okay. So so why does so that's why you see that if you just go and see the biggest squares have the narrowest confidence interval.
Yes, sir.
And it's not about crossing the line.
Okay, sir.
And what you were saying about the line crossing, saying that the study is not, is that correct? I mean, what were you saying about the line crossing? What were you meaning about the line crossing?
Sir, it will in this study, if the line is crossing, it will be less conclusive whether to conclude whether there will be increased risk of cancer with the therapy which we are studying or not.
Is that
Why?
what it means? Crossing the line means that, or
It crossing means it will favor the other group.
So
See, the
we are not
favor and
talking about
non-favor
favoring
here
any group
is
here. There is no favoring any group. What is crossing the line? Crossing the line only means that there is uncertainty in your sample. So crossing the line only means that it can either be 0.9 or it can be or 1.1. If it didn't cross the line, and suppose the line was between 0.4 to 0.6, any value that you got in the population would still be on the left. So there wasn't any uncertainty there.
Okay.
If it crosses the line and the line ranges from 0.8 to 1.2, then all it tells you that some values might be 0.8, some values might be 0.9, some values might be 1.1. So there's uncertainty. We don't know if it is going to fall here or here.
Okay, sir.
In a population, not in this study. This study you already have. This study is the central estimate.
Yes, sir.
So the central dot is what this study has seen. But if you take those results and that kind of sample and try to extrapolate it to the population, you don't know if it is going to fall at 0.8 or 0.9 or 1.1 or 1.3 or 1.7. So that is why it is variable or it is uncertain.
Okay, sir. Okay.
I hope that's clear.
Yes.
Because it's not favoring one or the other. If the line crosses this thing, if the line crosses this thing, suppose let's take the last one, Hassan 2022. According to your understanding, which one is it favoring?
The last one, the confidence interval is crossing the line of
Is it crossing the line? So which one is it favoring?
Again, it is
Because you said it's favoring one thing or the other.
uncertain, sir, because it is
Yeah,
crossing.
that is now. Okay.
Yes.
Okay, yeah, go
Go
ahead.
to the next slide, the funnel
Yeah.
plot you were describing.
Yes, ma'am.
Okay.
So the funnel
So
plot.
how do you interpret this?
Yes. Ma'am, here the points are evenly spread on both the sides of the pooled effect estimate, which is the center line, which indicates low likelihood of publication bias or the small study effect.
What is
Hello.
publication bias?
Ma'am, publication bias is the probability of including studies which favor the current meta-analysis, or the probability of excluding the studies which have negative results.
Yeah, no, not to include. That just means that they've given more weightage to studies which have positive results.
Positive results. Yes, ma'am. Should I proceed?
Yes. That's clear to the others? Okay.
Yeah. So here, individual pooled hazard ratio for TNF inhibitors is again given, which is 0.94. The pooled hazard ratio for rituximab group was 0.81, and that for vedolizumab group was 0.49. Now, should we prescribe? So the answer to the question, that should we prescribe targeted therapy in inflammatory arthritis patients with history of cancer? So yeah, there's no indication of increased risk of new cancer or cancer recurrence with biological or targeted synthetic group compared to conventional synthetic TMAR group, and no significant difference in risk of cancer between TNF and non-TNF biologicals was found here, though most of the studies have focused only on TNF inhibitors. Stratified analysis, histological based on histological type of cancer, time from initial cancer diagnosis to initiation of targeted therapy, and duration of targeted therapy. Considering histological type, solid cancers were studied in 6 studies, of which the pooled hazard ratio was 0.89%. Non-melanoma skin cancers were studied in 3 studies, of which the pooled hazard ratio was 1.23%. Hence, to conclude, with solid malignancy, there is no increased risk of new cancer or cancer recurrences using TNF inhibitors, whereas slight increase in risk of non-melanoma skin cancer is found with TNF inhibitors. Time from initial cancer diagnosis to initiation of targeted therapy. Now, if we start the targeted therapy within 5 years of cancer diagnosis, this was studied in 5 studies, and the pooled hazard ratio was 0.88%. And if we start with history more than 5 years, 3 studies were included in this, and the pooled hazard ratio was again 0.82%. Hence, after what duration of cancer diagnosis is it safe to initiate targeted therapy? Time of initiating targeted therapy since cancer diagnosis is not important, and the previous guidelines of avoiding use in recent cancers is scraped out in this study. Hence, addressing cancer-related risk factors for recurrence rather than time elapsed since initial cancer diagnosis is essential while evaluating the benefits of initiating or reinitiating targeted therapy. Duration of targeted therapy, that is the time for which the patient is exposed to targeted therapy. If it was less than 5 years, 11 were studied, of which all studied TNF inhibitors, and the pooled hazard ratio was 0.93%, was 993. And if they are exposed to TNFs for more than 5 years, the pooled hazard ratio is again 0.8. So, does prolonged exposure to targeted therapy increase the risk of cancer in inflammatory arthritis patient with cancer history? So, duration to which the patient is exposed to targeted therapy does not influence the occurrence of new cancer or cancer recurrence. Now, sensitivity analysis was conducted on patients only with inflammatory arthritis. 12 studies were included, all of which had rheumatoid arthritis, and the overall risk of new incident or cancer recurrence in patients with history of cancer with biologicals versus conventional synthetic was 1.03%. Now, this is the forest plot explaining the same. Now, only they retained most recent studies from each registry, of which the hazard ratio was 87%, and they combined only RA patients with latest registry data, and the hazard ratio was 0.99. Hence, they gave some overarching principles. The points are underpinned by EULAR recommendations for management of inflammatory arthritis. New onset or recurrent cancer can occur in patients with inflammatory arthritis with a history of cancer. Individualized risk of cancer recurrence needs to be assessed based on characteristics of the patient, cancer, and underlying inflammatory arthritis. Rheumatologist is responsible for management of patients with inflammatory arthritis and a history of cancer. Treatment of patients with inflammatory arthritis and a history of cancer should aim at optimizing outcomes and must be based on a shared decision between patient and the rheumatologist. They gave EULAR points to consider. Treating inflammatory arthritis effectively in patients with history of cancer is important to reduce the potential associated risk of malignancy. The risk of complications associated with undertreated inflammatory arthritis should be balanced against the potential risk of targeted anti-rheumatic therapy related cancer recurrence. The rheumatologist should engage with other specialties caring for cancer for co-management of patients with inflammatory arthritis and history of cancer. Appropriate targeted anti-rheumatic treatment can be initiated without delay in patients with cancer in remission. In patients with history of cancer, JAK inhibitors and abatacept may be used with caution and only in absence of therapeutic alternatives. When targeted anti-rheumatic therapy is indicated in patients with a history of solid cancer, TNF inhibitors may be preferred over other treatment. When targeted anti-rheumatic therapy is indicated in patients with history of lymphoma, B-cell depleting therapy may be preferred over other treatment options. And when patients with history of malignancy not in remission and active inflammatory arthritis, the decision regarding targeted anti-rheumatic therapy should be based on shared decision between patient, caring oncologist and a rheumatologist. Limitations of the study. Heterogeneity was present among the study. There was limited long-term follow-up. Risk of bias like selection bias, publication bias, lack of head-to-head comparison. Potential confounding factors like stage of cancer, type of inflammatory arthritis, and other comorbidities were not taken into consideration. No study analyzed patients in whom cancer was not in remission, and variability was present in the treatment protocol. Hence, to conclude, targeted therapies do not confer a high risk of new cancer or cancer recurrence in inflammatory arthritis patients with cancer history as compared to conventional synthetic DMARD. However, the data is limited on non-TNF drugs. Time since cancer diagnosis to initiation of targeted therapy has no increased risk of new cancer or cancer recurrence, and duration to which the targeted therapy duration patient is exposed does not increase the risk of new or recurrent cancer. Hence, importance of individualized risk assessment and shared decision making is important. Now, I critically appraise this article based on the Critical Appraisal Skills Program checklist. Section A, is the study design valid for a systemic review? Did the systemic review address a clearly focused research question? Yes. The study aimed to inform EULAR points to consider on initiation of targeted therapies in inflammatory arthritis patient and history of cancer, and it followed a PICOT framework as we have already seen. Did the researchers search for appropriate study design to answer the research question? Yes, it is a cohort registry-based study. Section B, is the systemic review methodically sound? Were all the relevant primary research studies likely to have been included in the systematic review? A, searching for primary research studies, yes. Major databases like PubMed via Medline and Embase were used. There was no language restriction. Appropriate screening, inclusion, exclusion criteria are clearly mentioned. A Prisma-based flow diagram was given, including number of patients screened out, excluded with given reasons, and information regarding unpublished data is not provided. Screening primary search from the search. Yes, studies reporting relative major risk of patients with history of cancer initiated on targeted therapy or conventional synthetic, regardless of time since cancer diagnosis were included. There was a robust process to screen the primary research studies. There were 2 reviewers who screened the titles and abstracts to assess the eligibility, and disagreement was solved by discussion. Selecting primary research studies to include in the systemic review. Yes, again, a robust process including 2 independent reviewers was taken, and abstracts to assess eligibility and disagreement was solved by discussion. All the potentially eligible articles were read to full text to decide whether they fulfill the inclusion criteria or not. Summarizing the search and its output. Yes, summarization was done using a Prisma-based flow chart. Did the author assess the validity or methodological rigor of the studies in systematic review? Yes. A Newcastle-Ottawa scale quality assessment was done for each study included in the meta-analysis. Risk of bias was assessed by Robbins-1 tool. Heterogeneity was assessed by I-square statistics and Cochrane's Q test, and publication bias by a funnel plot. Did the researcher extract and present information from individual primary studies appropriately and transparently? Extraction of data, yes. Ryan's online tool was used for data extraction. Presentation of data. Tables were used to present key characteristics of each study, and results of individual outcome were presented in the forest plot. Section C. Are the results of systematic review trustworthy? Did the researcher analyze the pooled results of individual primary research appropriately? Yes. Hazard ratio was with 95% confidence interval was the measure of effect. It was a random effect model because of heterogeneity among the studies, which was assessed by I-square statistics. Sensitivity analysis was performed, and funnel plot was used for potential biases. Subgroup analysis and meta-regression was not included. Did the researcher report any limitation of systemic review? And if so, do the limitations discussed cover all the issues you have identified during critical appraisal? Yes. Lack of long-term follow-up, impact of heterogeneity, effect of publication bias, lack of data on non-TNF drugs and JAK inhibitors, and data on patients in whom cancer is not in remission were the limitations which were included in the article. Subgroup analysis and meta-regression were again not performed. And would the benefit of acting upon the results outweigh any potential disadvantages, harms, and or additional demand for resource associated with acting upon the results? They may partially be applied, as much of the data on non-TNF inhibitors, JAK inhibitors is not available, which may again contribute to more specificity of the results. Are the results of systemic review relevant locally? Can the results of systemic review be applied to your local population in your local settings or context? Again, they can be partially applied, as the institute in which I work is a government institute, and monitoring of cancer is not possible in this institute. Timely monitoring is not possible due to lack of follow-up of from the patient side. Data on non-TNF is not again available. JAK inhibitors, which are available at our institute, the data on that is not available. Data on long-term follow-up is again not available. And effect of confounders like stage of cancer, type of arthritis, and comorbidities are not studied. Will the implementation of results represent greater value for service users in your population? Certainly, this can help, because controlling disease activity in patients with cancer is a big question, and for rheumatologists as well and oncologists. So combined decision from rheumatology and oncology side regarding use of biologicals can help patients to control disease activity. What is your conclusion about the systemic review? Can it support clinical based decision making? Yes, it can surely support the clinical-based decision making, and it has certainly added to our knowledge about TNF inhibitors and risk of cancer. But more data is awaited, which will further lead to precise decision making. Future directions. Need of additional data on inflammatory rheumatic diseases other than rheumatoid arthritis can be expected. Studies on other drugs other than TNF inhibitors like IL-12/23 to IL-23, IL-17, JAK-STAT will add to our insight. Studies with longer follow-up duration are required. Standardized guidelines for initiation and monitoring of targeted therapy in this population will be of much use, and more data on rare cancer types and follow-up protocol for cancer surveillance is important. Thank you.
Yeah, thanks, Shruti. It was a good presentation.
Thank you, ma'am.
Yeah, any further questions?
Yeah, I think it was excellently done. And she has highlighted actually the most important thing is we are worried about the concern of malignancy on JAK inhibitors that has not been studied here. And the other thing, I think there's a question in the chat box also. There are rheumatoid arthritis is also, there are other malignancies associated with rheumatic diseases. So that can itself happen unrelated to the general, besides general population. That's another, I think rest of it was covered very well.
Okay. Sanat and Sushant, you want to ask her anything?
No, ma'am. I think she presented very well.
Okay,
Yeah,
so
that was good. Yeah.
yeah. And I think the other residents have also understood how the study was read and done. Deepak wants to say something, I think.
Yeah.
There is always some uncertainty regarding the use of biological treatments in arthritis. And yes, so this paper definitely helps guide us in the use. We were, not very comfortable using these biologicals in cancers, but now this SLR has helped us reach some conclusion for this. So I think, ma'am, in interest of time, should we?
Yeah. I think it was very well done. Very good effort. Thank you, Varsha, Sanat, and Sushant.
Thank you.
Yeah,
Thank you.
Thank you so much. Yeah.
Thank you for
Okay,
giving
so-
the opportunity, ma'am.
Yeah,
Thank
very
you.
well done, Shruti. Yeah,
Well-
very good. Yeah.
Thank you.
Okay. So you
Thank
can
you,
stop
ma'am.
sharing your screen. Yeah. Okay. Bye-bye. Yeah. Stay for the next talk. That is by Colonel Dr. Arun Hegde. Arun, are you there?
Yes, ma'am, I'm there.
Yeah, you can start sharing the slides by introducing. Yeah, so on behalf of Maharashtra Rheumatology Association, it gives me great pleasure to invite Colonel Dr. Arun Hegde. He's the professor of medicine and rheumatologist at the Military Hospital, Belagavi. He's MD Medicine and DNB Rheumatology. He's the editor, he's on the editorial and reviewer roles in various prestigious journals, including Armed Forces Journal, Medical Journal. He's the associate editor there, reviewer for IJR, BMJ case reports. He has multiple publications to his credit. He is known for conducting NFC workshops at IRECON, various publication workshops, and he's an MD examiner. His area of interest is vasculitis, lupus, and IgG4 related disease, which is his topic today. And if I may add, he's an ardent birder too. Welcome, Dr. Arun. You
Thank
can
you, ma'am.
start. Yeah, nice to have you today. You can start sharing your slides.
Yes, ma'am.
So today he's going to speak to us on IgG4 related disease and the updates regarding this entity, which is rare, many times difficult to diagnose. Yes, just go to the slideshow.
Is my screen visible, ma'am?
Yeah. Yes, we can see your first slide. Yeah.
Yes.
Over to you, Dr. Arun.
So thank you, Kavita ma'am and the MRA for giving me this opportunity to speak on one of the topics which is a little close to my heart. I remember Kavita ma'am asking me to speak on something which has not been discussed on this forum before, and to my mind, this topic was one of the first topics which came because I had seen few rare presentations of this disease, and I've always encountered that this diagnosis is often missed, or it is really difficult to pick these cases up because especially it's a multi-speciality illness and it keeps going to various specialists in the hospital before finally landing up with the rheumatologist. So without wasting much time, I would plan to discuss my topic on the following subheadings. So we all know that IgG4 related disease is a fibroinflammatory condition characterized by tumefactive lesions. Tumefactive means tumor-like, associated with a dense lymphoplasmacytic infiltrate, which is rich in IgG4 positive plasma cells, storiform fibrosis, obliterative phlebitis, that is obliteration of veins, and often but not always an elevated serum IgG4 concentration. So it's a relatively new entity because it wasn't recognized as a systemic condition until 2003, so just around 20 years into this illness. Coming to the brief history of his disease, this disease was known by various names, since there are a lot of conditions which encompass the disease. The very first one being the presentation by Jan Mikulicz in 1888 as a case report at the Polish Medical Society. He presented a case of Mikulicz disease. You can see the representation of the patient whom he presented. So he presented with dacroidianitis and parotid gland swelling and submandibular swelling. This was followed in 1961 by Sals et al., who demonstrated a case of chronic pancreatitis with hypergammaglobulinemia. Subsequently, in 2001, it was Hamano et al. In Japan who demonstrated elevated serum levels of IgG4 and infiltration of IgG4 plasmacytes into the pancreas in a case of autoimmune pancreatitis, thereby first demonstrating the relationship between autoimmune pancreatitis and IgG4 related disease. But it was finally only in 2011 that the IgG4 related disease was discussed as a concept, and the preliminary criteria was drawn up finally by Omehara et al. In 2012. However, this criteria was just applicable to the Japanese population. It was only subsequently in 2019 that the ACR and the EULAR came up with the joint consensus criteria for IgG4 related disease. Coming to the epidemiology, it usually affects patients in the 5th to 7th decade. However, pediatric and older adults are not spared. It's a male predominant disease. The females generally used to get disease which is localized to the head and neck, whereas the males would get disease localized to the pancreatobiliary tract and the retroperitoneal tissue. Coming to the incidence of disease, the studies are very few, and it was only in the USA in a claims-based study where they could demonstrate an incidence of around 0.78 is to 1.39 per 1 lakh person years during 2015 to 2019 time period. And the point prevalence was 5.3 per 1 lakh people. However, this incidence is slightly higher in Japan, where it has been estimated to be around 3.1 is to 1 lakh. Coming to a little about this IgG4 molecule. So IgG4 molecule constitutes around 5% of the normal IgG total subclass in a healthy individual. So why is this? What is so characteristic about this molecule? You will be surprised to know that the IgG4 molecule is in fact an anti-inflammatory molecule and not a pro-inflammatory molecule. So what happens is that these IgG4 molecules are released from plasma cells as symmetric homobivalent antibodies. And because of the instability of these disulfide bonds between the heavy chains of IgG4, some IgG4 antibodies would form intra-chain disulfide bonds in the hinge region and consist of heavy chains linked by non-covalent interactions. So what happens is that there's a half and half antibody exchange in which a light and a heavy chain of one antibody goes and combines with a light and heavy chain of a different antibody. But before that, there is a intermediary FC-FC interaction, as you can see, is occurring here. What happens because of this FC interaction is that these FC-FC interactions shield these FC regions from other immune-mediated molecules. And what happens after the half and half antibody exchange is that this results in an asymmetric bispecific antibody, which is monovalent but has 2 antigen binding specific sites. So this results in ineffective immune complex formation with other IgG4 antibodies. The same thing is being depicted here. So you can see this half and half antibody exchange, and there's an antagonism of FC receptor because of this IgG4 combining with a similar IgG class IgG4, because of which there is no complement activation. So there is a limited ability to evoke downstream signaling and a pro-inflammatory response, thereby resulting in an anti-inflammatory response. So coming to the etiology and pathogenesis, it is still unclear despite 20 years of this disease being in existence. There is some genetic susceptibility. A few loci have been identified in type 1 autoimmune pancreatitis like the HRA-DRB1 and DQB1 in the Japanese. Certain susceptibility genes have also been identified like CTLA4, SPINK1, and FGFBP2. Certain etiological factors which have been predominantly seen in males has been the exposure to the industrial oils, metals, and cigarette smoking. Certain self-antigens have also been implicated like carbonic anhydrase 2 and 4, lactoferrin, amylase 2A, pancreatic trypsinogen, and there has been a role of innate immunity identified like PAMs and DAMs. So what happens here is there's an unknown antigen. So the PAMs and DAMs are recognized by the toll-like receptors and the NOD2 receptors on the basophils and the monocytes, resulting in a secretion of BAF. BAF, we all know, is B-cell activating factor, which is responsible for the class switch from IgG to IgG4. In addition, what happens is the basophils, they would secrete IL-13, and this IL-13 would go and result in the differentiation of naive T cells into Th2 type of T cells, and these Th2 cells will in turn secrete IL-4 and IL-5. IL-5 results in the activation of eosinophils, which is responsible for the eosinophilic infiltration in the IgG4 related diseases. In fact, an IL-4 will result in a further kind of further proliferation of more T cells into T helper type 2 cells. Also, this increased Th2 differentiation results in recruitment of Treg cells, which in turn would secrete IL-10 and TGF-beta. TGF-beta, as we all know, will promote fibrosis. IL-10 will further lead to the proliferation of more of T follicular helper cells. Naive T cells secrete IL-6 and IL-21, which would again further lead to the proliferation of T follicular helper cells, which lead to the formation of germinal centers and plasmacytes, which would release a lot of autoantibodies. So this is the reason for the increased fibrosis. A similar thing, this previous depiction of the pathogenesis was well elicited in the Nature Reviews Rheumatology 2014 edition. So then Nature Reviews came out with one more article just last month. So 10 years hence, there has not been much change in the understanding of the disease. As you can see, the same thing has been depicted here. The only additional thing which happens here is they have implicated the MER-TK macrophage, which in turn produces TGF-beta and IL-10, which further leads to fibroblast proliferation. What basically has been depicted here is a germinal center where the antigen presentation has happened by the follicular dendritic cell and the T follicular helper cell, which has resulted in the activation of the B cells, which migrate outside the germinal cells into the tissues. And these further lead to the activation of the cytotoxic T cells, which release a lot of perforin and granazine, which are pro-apoptotic molecules, leading to apoptosis. They also release TGF-beta and IL-1 beta, and interferon gamma, which further recruit more fibroblasts. Similarly, the MER-TK macrophages, the new cell implicated also by a process known as efferocytosis, causes more apoptosis, and it also releases TGF-beta and IL-10, which leads to more fibrosis. In addition, the plasmablasts secrete a lot of IgG4 and IgG1 antibodies, as well as IgE, and they also secrete PDGF-beta and lysyl oxidase, which is known as LOXL2, which also leads to more fibroblast proliferation and the extensive fibrosis, which you see in this particular disease. Coming to the clinical features, the presentation is subacute. The symptoms and organ dysfunction can last for months to even years, resulting in the patient visiting one specialist after another and before finally landing up to the rheumatologist if he's lucky. The disease is typically characterized by a remitting and relapsing course. It can progress very haltingly, then there can be static periods with spontaneous improvements in between and long periods of disease quiescence. And it can exist in multiple organs at the same time. Patients can manifest with weight loss of around 5 to 10 kilos. What is unusual is fever and hectic presentations. However, all patients will have fatigue if the disease affects multiple organ systems. Some patients might also have arthralgias and enthesopathies. So this is a depiction. The figure on the left is a depiction from NEJM, which had come out with a beautiful article, one of the first review articles on this subject, which came out in the year 2010-12. So you can see from head to toe the various organs which can be affected, right from the pituitary gland to the prostate gland. And we would be discussing these some of these manifestations as we go ahead. So starting with the orbit, one can have periorbital swelling leading to proptosis. Less common manifestations can be in the form of scleritis. You can have nasolacrimal duct obstruction, and also compression of the peripheral nerves in the area of the orbit in the form of the trigeminal and infraorbital nerves. You can see a CT scan on the right, where you can see this soft tissue around the orbit. Coming to the salivary glands, both the major and the minor salivary glands can be affected. The Mikulicz disease, we all know, is a combination of dacroadenitis and enlargement of the parotid and the submandibular glands, which was the first described entity which is encompassed in the IgG4 disease spectrum. You can also have isolated enlargement of the submandibular glands. You can have extensive parotid disease in isolation. You can even have sublingual gland enlargement. And you can also have xerostomia like you have in Sjogren's. Only thing is that the xerostomia usually is less severe and usually improves with immune suppression. Coming to the ear, nose, and throat, this head-neck disease, of which this ear, nose, and throat forms a sub-entity. These are usually associated with some sort of allergic manifestations in the form of allergic rhinitis, nasal polyps, chronic sinusitis, nasal obstruction, and rhinorrhea. There can be a long-standing history of allergy elicited in these people. You can have history of asthma, mild eosinophilia, and the peripheral blood would show mild to moderate peripheral eosinophilia up to 20% of the total leukocytes. You can even have high serum IgE concentration. They can go up to more than 10 times the upper limit of normal. A newly diagnosed entity has been inflammation in the pharynx, hypopharynx, and the Waldeck's ring. You can have mass destructive lesions in the paranasal sinuses. You can have tracheal inflammation and vocal cord involvement. There's an image on the right where you can see the subglottic stenosis, which is because of IgG4 related disease. This, I think, was published by one of our Indian scholars in one of the journals. You can have destructive lesions in the mid layer also. It can also affect the thyroid gland. The Riedel's thyroiditis has also been linked convincingly to IgG4 related disease. You can have fibrosing Hashimoto's thyroiditis. So you can see almost all the glands in the head neck region can be affected by this particular IgG4 related disease. You can have lymphadenopathy, which can even be generalized or localized. Usually it is adjacent to the affected organs. Lymph nodes usually are 1 to 3 centimeter non-tender. Cervical, supraclavicular, submandibular, axillary, hilar, mediastinal, paraaortic, retroperitoneal, and guanal nodes all have been described in lymph node involvement in IgG4 related disease. FNAC is unlikely to, FNAC or lymph node biopsy is unlikely to show the degree of fibrosis, which you would usually expect in IgG4 related disease vis-a-vis other organs which are biopsied. You can also have aortitis. You can get the thoracic aorta involvement. You can have aneurysms. You can have dissections. Usually, it's an incidental radiological finding when you are scanning for something else. However, it classically spares the subclavian, which usually gets involved in Takayasus. Recent case reports have even documented involvement of the coronary arteries. So another important entity is what we used to earlier know as idiopathic retroperitoneal fibrosis or Ormond's disease. Now this has been reclassified within a larger disease group, and now we call it as a chronic periaortitis. So it has three major components: IgG4 related retroperitoneal fibrosis, IgG4 related abdominal aortitis, and IgG4 related perianeurysmal fibrosis. So it's usually the periaortitis is usually, again, it's a very subtle presentation and non-specific symptoms are there, resulting in considerable diagnostic delay. The symptoms could be in the form of poorly localized pain in the back, flank pain, lower abdominal pain, radiating to the thighs. A patient can present with leg edema and hydronephrosis from the involvement of the ureters. So three sites basically. One is the periaortic site. There is a connective tissue found around the abdominal aorta, or you can have periuretral, which can lead to hydronephrosis because of ureteral obstruction, or you can have plaque-like mass, which involves the retroperitoneum in around 2/3 of the cases. So this is the PET image. You can see the increased PET metabolically active area around the aorta, and this is post-treatment. So PET is a very important modality to monitor disease progress after treatment. So in advanced disease, what happens is that the ratio of IgG4 positive plasma cells to the total number of plasma cells is considered to be more helpful diagnostically than the overall number of IgG4 positive plasma cells which are seen per high power fluid. And the usual features which are identified in this retroperitoneal fibrosis is the storiform fibrosis and the obliterative phlebitis. The lymphoplasma septic infiltrate might or might not be seen if the disease has been of a long-standing nature. So lung is a slightly different kind of presentation. It's got the highest diversity of the clinical and etiological presentations. What is different in the lung is that you can have various neutrophil infiltrations, which normally would not be seen in a routine IgG4 related disease. You can have a thickening of the bronchovascular bundle on CT, which is a characteristic imaging finding. You can have pulmonary nodules. You can have GGOs like an ILD. You can have pleural thickening. If you go to the kidneys, the tubular intestinal nephritis is the most characteristic presentation. How it differs from the other usual TINs you see is that there is a low concentration of the complement. And you can also have advanced renal dysfunction. You can have ESRD. You can have subnephrotic proteinuria, and people can also present with the membranous glomerulonephritis. So this is what the CT would look like in the kidney involvement. You can see the soft tissue around the kidney. Long-standing disease, the kidneys can even become atrophic, like in this case. Pancreas, this was one of the first organs to be associated with the high serum IgG4 concentrations. The autoimmune pancreatitis, we all know there are two types, type 1 and type 2. And it is the type 1 which is associated with the IgG4 related disease and not the type 2. So most common clinical presentation usually would be obstructive jaundice. That is not because of the pancreatitis per se, but it is because of all these patients would have some amount of concomitant IgG4 related sclerosing cholangitis, which would lead to the obstructive jaundice. The CT in pancreatitis is very characteristic. You can see a diffuse pancreatic enlargement with delayed enhancement and a capsule-like low-density rim. ERCP is again very highly specific. You see diffuse irregular narrowing of the main pancreatic duct. These cases of type 1 AIP are very, very prone to pancreatic CA as well as pancreatic stones. Certain orphan organ involvements which have recently been published as case reports. One of them is hypertrophic pachymeningitis. You can also have sclerosing lesions of both the mediastinum and the mesentery. You can, on the CT scan on the right, you can see a image of fibrosing mediastinitis, which can result in compression of the vital structures in the mediastinum. You can also have presentations in the skin in the form of erythematous papules. And you can also have peripheral nerve masses up to 3 centimeters in diameter. So this is an interesting depiction of the various organ involvements. The organ involvements on my left are the ones which are associated commonly, and the organ involvements on the right are the ones which are recently being picked up and considered uncommon. So the common ones are the pseudotumor, Mikulicz disease, eosinophilic angiocentric fibrosis, Kuttner's tumors, idiopathic cervical fibrosis, reduced thyroiditis, inflammatory pseudotumors in the lung, autoimmune pancreatitis, sclerosing cholangitis, inflammatory kidney pseudotumors, chronic sclerosing aortitis, inflammatory abdominal aortitis, and retroperitoneal fibrosis. The rarer ones are the idiopathic orbital inflammations, interstitial pneumonias, pulmonary fibrosis, sclerosing mastitis, constrictive pericarditis, sclerosing angiomatoid nodular transformation, sclerosing mesenteritis, TIN, membranous nephropathy, and cutaneous pseudolymphoma. So this article, I would encourage all the residents to read. It's a very interesting article which has been published in the Current Opinion Rheumatology in year 2012. So Professor Johnstone had taken a lecture on IgG4 disease during COVID, and I remember attending that lecture. And he says, and he's one of the authorities on IgG4 related disease, and he used to say that the cumulative damage from IgG4 related disease is too much, and these are the following damages which can result, more of a permanent kind. You can have exocrine and endocrine pancreatic failure. You can have chronic hepatobiliary failure, kidney failure. You can have hydronephrosis and chronic ureteral stents. You can have orbital lesions, which are very destructive, bone destructive sinus lesions. You can have pituitary failure. You can have coronary artery lesions. However, what organ it does not affect is the long bones. Yet to see or read about IgG4 related disease affecting the long bones. Coming to the histopath, we all know histopath is the key to diagnosis. Three central features, which I already mentioned: lymphoplasmacytic infiltrate, obliterative phlebitis, and storiform fibrosis. The image on the right indicates a lymphoplasmacytic infiltrate. The lymphocytes and plasmacyte and the plasma cells tend to be polyclonal in nature. You can have eosinophils also, as I explained in the pathophysiology, and it can resemble a eosinophilic organopathy. What is rare is neutrophil infiltration, which is usually seen only in the lungs. And certain things which are atypical, which would lead away from the diagnosis and pathology, is one is necrosis, the other is granulomas, and the third is xanthogranulomatous changes. The image on the right depicts storiform fibrosis, which is a prerequisite for diagnosis. Some fibrosis would be present in all cases, and it starts very, very quick. That is, even after a short symptom period, you can have some amount of fibrosis. And usually, the ideal description which they mention is books that the collagen fibers are readily arranged and they seem to weave through the tissue. This is the description which is described for the storiform fibrosis. The only issue with the storiform fibrosis is that it's patchy in distribution, and sometimes one might miss if one does a needle biopsy. So multiple maybe specimens might be required. However, the issue is that sometimes the specimens might be very difficult to obtain, depending on where the lesion lies. And the fibrosis, if the disease is long-standing, that is likely to predominate in a long-standing disease. And however, it still remains, the specificity still remains a little low. Obliterative phlebitis is the obliteration of the veins. You can have either partial or complete obliteration of the medium-sized veins. And usually these veins would appear next to an inflammatory nodule, as you can see in the picture. And sometimes you can identify these veins only on elastin staining. So one has to distinguish this obliterative phlebitis from the fibrous venous obstruction, in which you can see in a primary sclerosing cholangitis kind of case, where usually there would be no inflammation. So certain unique organ-specific pathologies, what you would notice on the slide is again from current opinion, is that in the head and neck lesions like the lacrimal gland, the salivary gland, and you can see that the typical storiform fibrosis is relatively uncommon, and also most of these lacrimal and salivary glands would lack the characteristic obliterative phlebitis. So you would just maybe get some amount of inflammation. So the diagnosis in these head and neck lesions is a little difficult and would require a mix of clinical, radiological, and serological evaluation. Also, another thing to note, which I already mentioned, is that the lymph node also lacks obliterative phlebitis, and the other characteristic lesion in the lung, which is the neutrophilic infiltration, which is not seen in other tissues. And the lung also is characteristically known to have an obliterative arthritis. So other places it's the obliterative phlebitis, but here in lung it is the obliterative arthritis. So again, it is a unique feature of the lung. Immunostaining is another very important part of histopathology. So you can have a high number of IgG4 positive plasma cells at tissue sites. So these can be there even if the serum IgG4 levels are normal. You can see here the IgG4 positive plasma cells. And as I told you that this kind of picture helps it to differentiate from other fibrosing diseases like primary sclerosing cholangitis and Castleman's disease. So there are certain caveats in the interpretation of tissue IgG4 stains. So IgG4 positive plasma cells, these can be present diffusely throughout the lesion of the IgG4 related disease. However, focal aggregations are atypical. And as per the tissue, the absolute number of IgG4 positive plasma cells varies. So it has to be interpreted with caution. So if it is adenitis, so number more than 100 cells per high power field is considered significant, whereas in the pancreas is only 50 cells per high power field. So this is another interesting depiction of whatever I've already told on one figure. Coming to the morphological changes, as far as the organs like the pancreas and the kidney are there, they would be diffusely enlarged, as you saw in the CT scan images. However, in ductal organs like the bile duct and the bronchus, one would get what is known as a pipe stem appearance with diffuse wall thickening. You can see the top image labeled as G, where the pipe stem appearance can be seen. You can also have small nodules within an otherwise normal looking organ, as you can see in the image on the right. So diagnosis, as I told you, is a mix of clinical examination, histopath, imaging, and serology. Tissue biopsy remains the gold standard. Imaging, it's only the pancreas where it is considered diagnostic. Elsewhere, a tissue diagnosis would be important. And here comes the importance of FDG PET, because it's a very important modality both for diagnosis and further more important in follow-up and assessing response to therapy. Coming to serology and serum IgG4 levels, they are neither sufficiently sensitive nor specific. They are a useful screening tool. I'll speak about a little on detail regarding the serum IgG4 levels in the subsequent slide. However, it is unreliable as a single diagnostic marker. So these are the issues with IgG4 levels. Even in a typical organ like the pancreas, up to 20% of type 1 AIPs might have normal serum IgG4 concentrations. And high serum IgG4 concentration can seen in many inflammatory conditions as well as malignancies. And even 4 to 10% of healthy people would have a high serum IgG4 concentration. So it has to be interpreted really very, very cautiously. And to increase the diagnostic specificity, we have to look at the IgG4 by the total IgG ratio, which should be more than 10%, or the IgG1, which should be more than 24%. So both these things, if they are there, they increase the diagnostic specificity when all the IgG4 concentrations are only mildly raised. Also, one thing to know is there's a prozone phenomenon in estimation of the IgG4 levels, and that is why all those issues are there. And nephrometry analysis is also prone to error. So what's new? If you go through the Lancet article recently published, so what they have done is now they have divided this IgG4 related disease into 4 distinct compartments. So you can have pancreatico-biliary subtype, you can have the retroperitoneal subtype, you can have the head neck subtype, and the Mikulicz subtype. So the pancreatico-hepatobiliary disease is unique because it is male predominant, average age is around 60 years at presentation, and the serum IgG concentration is generally very high here. And you can have certain mimickers like PSC, which can mimic pancreatico-hepatobiliary disease. Coming to the retroperitoneum, we have retroperitoneal fibrosis, aortitis, and large vessel disease. Again, male predominant, 50 to 60 years. However, here the serum IgG4 concentrations are either normal or only mildly elevated. And the head neck disease, more in females, would include the salivary and lacrimal gland, adnexal orbital involvement. And age is again around 55 years of age. And the differential diagnosis here would comprise autoimmune polyangiitis and lymphomas. And the fourth is the Mikulicz disease, around 63 years of age, is again a male predominant disease. And here the serum IgG4 concentrations are again very high. Another thing which is new is to divide it into a fibrotic versus a proliferative phenotype. So the fibrotic phenotype would include retroperitoneal fibrosis, myelostenosis, renal steroiditis, and orbital sclerotumor and pachymeningitis. And the proliferative would include the pancreatobiliary, the lacrimal, salivary, and the kidney involvement. So the basic difference between these two is that the serum IgG4 levels, elevation of these IgG and IgG4 levels is less prominent in the fibrotic, while it is more in the proliferative type. Fibrotic types have very less inflammatory infiltrates and absent to low metabolic activity on PET, whereas the proliferative would have more metabolic activity. And the improvement in the fibrotic subtype in response to glucocorticoids or B-cell depletion is less brilliant compared to the more exuberant improvement which you would see in a proliferative subtype. So that comes to the question, have there been any diagnostic criteria for this? Yes, the first diagnostic criteria came up in the Japanese population by Omahara et al. In the year 2011. After that, it was only in 2019 that the ACR and ULAR came up with a classification criteria. So they would have some entry criteria followed by exclusion criteria and an inclusion criteria to classify it as IgG4 related disease. The only issue with this is that these are more for research purposes and not actually for diagnosis. Or there have been a more simpler revised comprehensive diagnostic criteria which have been introduced in 2020. published in the Nature Reviews Rheumatology. So these criteria, you would have evidence of, you can characterize IgG4 disease into definite, probable, or possible based on these criteria. So there are three basic criteria. The firstly would require a clinical and radiological feature in the form of one or more organs showing diffuse or localized swelling, or a mass or a nodule characteristic of IgG4 disease. Then you would have a serological criteria in the form of serum IgG4 levels more than 135 milligram per deciliter, and the pathological diagnosis in the form of a dense lymphoplasmatic infiltrate with fibrosis, the IgG4 to IgG ratio of more than 40% with IgG4 plasma cells more than 10, and a typical tissue fibrosis like soriform fibrosis or obliterative phlebitis. So you would call it definite if all the three criteria are met. You would call it probable if only the clinical criteria and the lab criteria are met. And you would call it possible if the clinical and the serological criteria are met. So coming to the treatment algorithm. So general principles of the treatment, because the disease is usually a slow progressive disease, so an urgent treatment might be seldom required. The caveats are if there is a ureteral obstruction or there is a biliary stent placement for a stenosis. Prompt treatment you would give to those individuals who are symptomatic or asymptomatic individuals who have evidence of progressive disease in vital organs as you would get on your imaging. However, if the disease is asymptomatic and of a limited variety, you would require only careful monitoring. And the goal of therapy would be to prevent tissue fibrosis. So this is an interesting treatment algorithm which has just published last month in the Nature Reviews Rheumatology. So as I mentioned, urgent treatment is for life-threatening manifestations. Coming to the medical therapy, glucocorticoids is the cornerstone of therapy. So if there is no contraindication to glucocorticoids, you go ahead with glucocorticoid monotherapy. Prednisolone at the rate of 0.6 milligram per kg per day. You would maintain this dose for maybe 2 to 4 weeks and then go on a progressive taper for the next 4 to 6 months. And however, the difficulty with the IgG4 is that it's little difficult to completely take off the steroids. So you might have to maintain them on a maybe a maintenance dose of around 5 milligrams. If there is any partial contraindications to glucocorticoids, you can go in for a combination therapy in the form of low-dose glucocorticoids at 10 to 15 milligram of prednisolone, combined with either rituximab or some of the other newer B-cell depleting antibodies, which I would be discussing shortly. Or you can add a CS-DMARD in the form of azathioprine at 2 milligram per kg or methotrexate up to 20 milligram per week, or even MMF or cyclophosphamide is acceptable as a add-on therapy. If there is an absolute contraindication, you can straight away go ahead with the rituximab monotherapy in the form of 2 doses, 1 gram, 2 weeks apart. And basically, you have to target remission. And if at any time during the management you have a relapse, you have to switch on to a alternate mode of therapy. So are there any real biomarkers? Yeah, a lot of biomarkers have been studied, but nothing is really very, very sacrosanct. Only if you have a high serum IgG4 level at beginning, it serves as a good biomarker for monitoring the treatment. Then you have other things like the serum IgG4, IgG ratio, the serum IgE levels. If you have hypertrophic pachymeningitis, you have the CSF IgG4 indices. You have the peripheral blood plasma blast and plasma levels, because reduced levels would suggest active disease, particularly in TIN cases. And PET, as I mentioned, is again a very important entity. For disease activity, again, the same things can be monitored. Serum ASR and CRP are these correlate with disease activity, especially in retroperitoneal and aortic involvement cases. So this was another interesting article by Professor John Stone. So what have we learned over the last 20 years as far as this disease is concerned? So first of all, the first lesson we learned is that if you all listened to his lecture, it was the inaugural lecture in Aerocon 2024 in Bangalore. So the first lesson was that the IgG4 is a vasculitis. It's prone to vascular tropism. You can have involvement of the the large and the medium-sized arteries, including the coronaries, in almost you can see even the small vessels also getting involved. So basically, and even the veins can be involved. So basically, it's a variable vessel vasculitis, just like maybe a Behçet's. And other thing is that it is more common in males. It's a male predominant disease. The male to female ratio is maybe you can say 2.2:1. And the age is the males is 63 years versus 58 years in females. Where the disease divergence emerges is after 40 years of age, where the male predominant disease tends to be more than the females. The third lesson which we learned is that there is no specific diagnostic pathology. So the diagnosis can only be achieved by integrating data, as I mentioned, from clinical, serological, radiological, and pathological realms. And the only thing which might be suggestive is the IgG4 by IgG plus plasma cell ratio, which is also a part of the criteria, which is more than 40% is considered suggestive. The things which lead you away from the diagnosis of IgG4 related disease are the presence of neutrophils and necrosis, which would take you more towards maybe a diagnosis of ANCA-associated vasculitis. Presence of granulomas would suggest GPA or sarcoid or any other granulomatous disease. And histocytic infiltrates would suggest something like a Rosai-Dorfman or a Erdheim-Chester disease. The fourth thing which we learned is that the serum IgG4 concentration is a better marker than maybe the level of the anti-PR3 or the anti-MPO, which we see in ANCA-associated vasculitis. Usually because the measurements are generally elevated in almost 90% of the patients with IgG4, and serial measurements usually tend to be a reliable biomarker. And whenever we start this treatment and the levels are elevated at the start of treatment, there's a usual brisk decline in the serum levels initially, and then there's a more gradual decrease as the treatment progresses. And serum IgG4 may become greatly reduced after therapy but however, it might never reach a normal value. So that is to be remembered. We should, if the levels are not coming down to normal, that does not mean that the disease is not getting cured. Another thing is that if you're monitoring the disease and you see a sudden spurt in serum IgG4 levels, so it might indicate a return of active disease, maybe like a dsDNA level. And thing to remember is that even if there is a serum IgG4 concentration more than 5 times upper limit of normal, there's still a 25% chance that you might be dealing with a different disease. So certain caveats are always there. So as clinicians, we always say, don't treat the biomarker, and we always tell our residents. But however, in this case, rising serum IgG4 should never be ignored. And I quote Professor Stone that rising serum IgG4 concentration, if documented to be consistent and substantial over an interval of several weeks or cellular determination, it typically means that the disease is active, if not at the same site, but at some other site. So lesson 5, which we learned, are the B-cell therapy is gaining ascendancy now. The first small case series on rituximab came back a long way back in 2010, and it was only 13 years later that we had the Indigo trial in 2023, again published in the NEGM, using another B-cell molecule, obexelimab, and it was a phase 2 trial, and it was very encouraging. So now there's a phase 3 trial which is on. And in 2024, we have again NEGM in nebulizumab, again the mitigate trial, which showed the efficacy of this particular drug. So rituximab, as shown in the treatment algorithm, we tend to prefer it when there is an absolute contraindication to glucocorticoids, or there is a multisystemic disease, some vital organ involvement, inadequate response to glucocorticoids, or there's a relapse on GC remission, or who cannot satisfactorily reduce their GC doses to a minimum level. A little word on nebulizumab. It is a B-cell depleting CD19 monoclonal antibody. And it was the mitigate trial, a phase 3 randomized placebo-controlled trial. So they included adults who were receiving glucocorticoid treatments for a current IgG4-related disease flare. The protocol was in nebulizumab 300 milligram or placebo by IV infusion. And it's just like rituximab, day 1 and day 15, followed by week 26, with identical glucocorticoid tapers in both the groups to achieve a minimum of maybe a withdrawal at week 8. So results were published only in late 2024, and they found that as an endpoint, it achieved all the primary endpoints, and it reduced the risk of IgG4 related disease flare by almost 87% compared with placebo over 52 weeks. And even the incidence of side effects were very less. So this is the newer antibody, obexelimab. It's a humanized monoclonal antibody which ligates CD19 with its FEB portion, whereas its FC portion is engineered to engage the inhibitory FC gamma R2B receptor. So what it does is it inhibits the B cells without inducing any kind of B cell depletion. So as I said, the phase 3 placebo control trial is still recruiting, and maybe we have to wait for a few years to get some kind of results on this. Certain other investigational drugs have been Bruton tyrosine kinase inhibitors like rilzabrutinib and zanubrutinib. You have also telitacicept, which is a recombinant fusion protein, and belimumab, which is being used in SLE, that is also being tried. Certain mimics which we should know, which we keep. So this is again been published last month. So the common mimics are Erdheim-Chester's disease, multicentric Castleman disease, sarcoidosis, large vessel vasculitis, and GPA. The things which we should know I have highlighted, like pituitary involvement would be more frequent in Erdheim-Chester's, retroorbital infiltration also more frequent in Erdheim-Chester's. Lacrimal and salivary is more frequent in IgG4. Chronic rhinosinusitis is more frequent in Erdheim-Chester's and GPA. Coming to the chest, periotitis is more frequent in Erdheim-Chester's and large vessel vasculitis. Lung involvement more frequent in Erdheim-Chester's and frequent in multicentric Castleman and sarcoid, and so on and so forth. So coming to the abdomen, important to know is the retroperitoneal fibrosis, and most frequent in IgG4 related disease, and slightly less frequent with the Erdheim-Chester's. So to conclude, IgG4 disease is a complex and multifaceted fibroinflammatory disease. The clinical phenotype can range from organ-limited to disseminated multisystemic forms. There is still a lack of disease-specific biomarkers, and diagnostic criteria are still under evolution, and they pose a lot of challenges. And you need to rule out a lot of infections and malignancies and a number of systemic conditions like I discussed before considering this particular entity. And the spectrum of IgG4 disease also includes forms with mild IgG4 plasma cell infiltration and normal serinosis IgG4, the nosology of which is still uncertain. So future directions would be better understanding the pathogenesis, maybe developing an effective animal model, which is still not there. Looking for safe and effective corticoid sparing treatment strategies like more of B cell targeted therapies, and looking at some better biomarkers, and maybe looking at a good, we have a responder index, but it is still not widely used. So basically have some kind of responder index to assess response, and look at better imaging modalities, and obviously have better ways to support our patients in their journey to this difficult illness. So why I became interested, like I said, so this was one of our rare presentations which we picked up. So this is a lady with middle ear disease which we picked up. So this is only the 5th reported case in the world. So our patient was a 31-year-old male with who came with otitis media, and she had a well-defined lesion in the left mastoid air cell with attico-antral involvement. And the biopsy had shown a lymphoplasmacytic infiltrate with storiform fibrosis. With IgG4 level of 104 for IPR field.
Prasad, just mute the others.
And the serum IgG4 levels are exactly not very high. However, she showed a very good response to prednisolone and rituximab. So these are some of the images of that particular case which we published in Indian Journal of Rheumatology. You can see the arrowheads on the CT and the PET, which is showing the middle ear mass. And on the right side is the histopathology plate, where you can see the immunostaining showing the IgG4 positive cells and the storiform fibrosis. This was in the subsequent year 2021, again from Command Hospital, Pune, when I was posted there, and I used to be an active part of the MRA. This was a skull base kind of presentation, which is again considered very rare and very difficult to pick up. So this was again the 5th reported case in the world for this particular entity. So this patient was a 52-year-old female. We picked her a little early at 4 months because our people were slightly more tuned to this particular entity because of a number of clinical meetings on this subject. She had presented with headache, giddiness, right ear pain, facial deviation, lower cranial nerve involvement, and involvement of the skull base, and very high serum IgG4 levels, and showed a very good response to steroids and rituximab. Coming to the work from, this is some of the images of that particular individual. You can see the on the left, the CT image showing the erosion of the sphenoid plate, and the PET image, which is showing the IgG4 mass and the arrowhead, and on the bottom plate you can see the MRI. The rightmost is the contrast enhanced MRI, which is showing the IgG4 related disease in the skull base. The histopathology plates again show the immunostaining on IgG4. So coming to the work from India, there have been two case series which have been presented. This one particular case series is from the All India Institute of Medical Sciences. They presented 13 cases of IgG4 related disease in 2022, and they found that their cases had a predominance of head neck involvement and retroperitoneal involvement. The Gangaram group has also published their series in Journal of Clinical Rheumatology in 2022. Lalit Dugal sir and his group, they presented 70 cases of IgG4 related. This is a big number. And even they had a predominance of head neck, orbit, and retroperitoneal fibrosis cases. So with that, I come to the end of the lecture. I thank you all, and I hope you didn't have to use a sprinkler system to keep you people awake. Thank you.
Excellent talk, Dr. Arun. Yes, IgG4 disease is complex, multifaceted, and it involves all organs head to toe, and probably doesn't affect the long bones, as I understood. So you also explained very nicely the pathogenesis paradox. I mean, IgG4 by itself is anti-inflammatory, but how that half and half antibody exchange eventually leads to cytotoxic T cells, etc. And necrotic, whenever there's a necrosis, you should think of vasculitis, even ANCA vasculitis.
Yes,
so there are many mimics that are important. I wanted to ask, there's a lot of plasma blasts involved in the pathogenesis. So is there any role or any evidence of anti-CD38, I mean, like this daratumumab and all? Is there any use of these drugs? Is there any study?
I couldn't come across any literature regarding this. Maybe there are a few articles which I might have missed regarding the use of these particular drugs. But personally, I don't remember reading anything regarding this. Maybe if any of the other people on the panel, if they know anything about this, they can share their experience.
Okay. Regarding sclerosing cholangitis, so, you just get patients with severe pancreatobiliary disease. So you said that in this, there is an extensive, I think, fibrosis. So I think primary sclerosing cholangitis, the MRCP appearance is slightly different, to differentiate.
Yes, ma'am. I think what I could make out is there's a difference on the histopath, as well as I think the appearance of ERCP or MRCP for IgG4 related disease is slightly different compared to the what we see on primary sclerosing. It's more of a fibrosing.
Yeah, primary sclerosing is more beaded, I think, and this is
more beaded. It's very distinctly different, and I think that is one of the key hallmarks on how you differentiate between primary and IgG4 related.
Varsha, you have a question. I think you can ask directly.
Yes. Colonel Arun, thank you so much. It was such a lucid, wonderful presentation. We've learned a lot from your lecture. I just wanted to know what would be your approach to retroperitoneal fibrosis in this disease, and how long would you consider GC therapy in various organ manifestations?
Thank you for this question. And what I would remember, the first case which I managed while at Army Hospital RNR was one Air Force pilot who came with this particular and he came to us from the onco physician, because that time people were not aware that this was way back in 2013 when I had just entered rheumatology, and nobody was aware about this illness because it had just come out in maybe 2012 in NEJM, and we were just having journal clubs at that time, like this particular day. So I remember that this patient required very extensive long-term rituximab regime. And I remember what I can recall is that we had managed him with glucocorticoids at pretty high dose, maybe more than 0.6 mg per kg as was recommended, maybe 1 mg with kg. And I think we also gave him a mini pulse to start with because he had severe hydronephrosis and ureteral obstruction. So he had initially gone for a DJ stenting and then he came to us from the urologist and we gave him a mini pulse of, I think, 500 for 3 days, followed by, we started with maybe 45 or 50 milligram of prednisolone, which we maintained for good around 4 to 6 weeks, followed by tapering. We added methotrexate, and then we also upfront we gave him rituximab because it was very, very extensive. And I remembered he required almost 6 to 8 cycles of rituximab, each cycle being day 0 and day 15, before he had resolution. But as of date, he is still hale and hearty, and he's back to his flying.
That's wonderful to know.
So how do you decide how long to give the rituximab, or if you're giving only steroids, when to add rituximab?
Ma'am, in this case, we had decided because we had done a lot of serial PETs in this case, and the initial response to the glucocorticoid was a little inadequate. So now this algorithm has come up, which says that when you find that maybe 2-3 months of glucocorticoids, you're not finding any kind of relief. This is all practical experience. You find that the lesion, maybe repeat a PET or a MR and see that the lesion is not regressing. Maybe an upfront rituximab goes a long way in improving the quality of life of these patients.
And regarding serum biomarkers, I think you said you can do IgG4 and IgG ratio, right?
Yes, ma'am.
What about CD38 levels? Do you recommend 38? Yeah,
I don't think that's
plasma plus.
I don't think it's yet come into any of the recommendations, ma'am. So we are still happy with doing our complements and but complements again only in TIN they have a role, and basically we monitor only with the inflammatory markers ESR and CRP. Some kind of in retroperitoneal fibrosis at least it has got a good role, and in aortitis, which we would commonly see in this part of the country apart from the head neck disease. And the serum levels, what I have noticed in my last maybe 10-11 years in rheumatology is that like most of what the articles say in the Western countries, if you have a high level at presentation, it remains a very good marker for assessing the disease response to therapy. So any maybe a brisk response initially followed by a more gradual response as the disease recovers, and a sudden spurt in the disease level would indicate that the disease is coming back, and maybe you would repeat an imaging and see like you can have diseases in 2 different places coming up at the same time. You can have a aortitis with a thyroiditis, or like 2 different organs where the IgG4 is getting involved. So that is how I would look at it. But I think the experience varies across different centers, and different rheumatologists would have different perspective on this.
Excellent, and thank you for sharing your publications and even the other Indian literature that you have. So we had an excellent discussion. Varsha, any more questions?
Yeah, there's one more question in the chat box. Kindly guide how to approach isolated hypophysitis. Which steroid sparing agent to choose, if at all they have a role?
I think, as I mentioned, hypophysitis is a very, very orphan presentation of IgG4 related disease, and I have yet to come across, I don't know, yet to come across. There are a few case reports. I think one has to go through them. Personally, I have not encountered, so I am not in a position to comment on this because I've never personally managed it.
Involve the endocrine team also, because there'll be a lot of
obviously
hormonal
anything to do with the pituitary axis, we have to involve them.
Yes. Okay, anybody else? Any questions? Okay, I think we had an excellent session, a very exhaustive review, and with your experience also. Thank you so much, Dr. Arun, for joining us today, sparing time on your Sunday. Thank you, Varsha, for conducting an excellent journal club. Okay.
Most welcome.
Thank you, everybody, for joining us.
Thank you, ma'am, for this opportunity, and maybe we'll have more lectures.
Sessions. Yes. Thank you. Have a great day, everybody. Thank you, everybody, for joining us.
Bye-bye.
Thank you, ma'am. Bye, ma'am.
Good day to you. Yeah.